Hi everyone, welcome to INI Set November 2021 recall session. Here we are going to discuss the questions that were asked in INI Set November and that were from orthopedics. So this is a breakdown of all the questions that were there from orthopedics. We had roughly around 9 questions that came on the exam, and these were the topics how they were divided. A question from open fractures, from compartment syndrome, from instruments and tractions, from orthopedic oncology, 2 questions from nerve injuries. Obviously one question will always show up from osteoporosis, another question from Thomas test, and 1 question from applied anatomy. Now, before I begin, I must tell you that all of these questions are recall based questions. So all of you understand, right? The problem with recall based questions is that the information is recollected from the students who have written the exam. So the information may or may not be so accurate. So that is not the aim. The aim is not to get the exact answer of the exam or to reproduce the questions. The aim is to understand what the examiner was seeking and what were the topics that were asked, so that we are well prepared for the upcoming exams, right? So with that said, let's look at the first question. So this was a question: following a road traffic accident, a patient develops type 3A compound tibial fracture. Now arrange the external fixators in terms of stability, that is lowest to highest. Ilizarov, uniplanar with single rod, uniplanar with double rod, or biplanar. Now, obviously, you don't know what this is because you have not been taught of this. In classes, this was the first of its kind question. But don't worry about it. Basically, the question is asking you for a type 3A open fracture, if the doctor is using an external fixator, which external fixator is the most stable? Or he's asking you to arrange the external fixators in terms of stability from lowest to highest, right? So let's, before looking at the options, understand what these various types of external fixators are. So quick review: open fractures are classified by Gustilo-Anderson's classification. Type 1 and 2 are type 1 is less than 1 centimeter in size, type 2 is more than 1 but less than 10 centimeter size. Type 3 has 3A, B, and C. All of you know this. 3A is an open fracture with periosteal covering. 3B is an open fracture with periosteal stripping, and 3 is an open fracture with an associated vascular injury. And usually all three types, that is 3A, B, and C, are more than 10 centimeter, but that is not the fixed dimension. And these are the photographs of open fractures. You can clearly understand. Now, the management of open fracture is very interesting, and we all know this. The management of open fracture is twofold. First of all, you have to take care of the wound itself because that is more important, and so you do debridement and wound management by washing it with normal saline, sterile normal saline, povidone iodine, hydrogen peroxide. You remove the dead and necrotic tissue and you perform debridements. And the second thing is the management of the fracture itself. Now, obviously, you cannot put anything at the wound, because if you put a plate or a screw or a nail or a rod, it's a foreign object and it can increase the risk of infection. And you cannot put a POP slab to cover up the wound, because if you do that, who will do the dressings that are required for open fracture management? So in that case, open fracture management, I told you to remember, that is managed by external fixator. So far, till this point, all of you know everything that we have discussed so far. But now you don't know what are the types of external fixators that we apply. So that is what the examiner has done. He has taken a very frequently asked topic and moved it up a notch. And so this is why we need to know what are the types of external fixators. Now, the external fixators, or the frames that we use to fix the bone outside the body, can be divided into uniplanar, biplanar, or ring fixators. Okay, and there are hybrid types also that use uniplanar with ring fixator components. But just bear with me. I'll make you understand. Don't worry about it. Now, uniplanar external fixators can be unilateral or can be bilateral. Biplanar again can be unilateral and bilateral, and there can be ring fixators. So let me show you this. So this is the image of tibia, and there is an external fixator applied where the rod is on one side and the fixation is in one plane. So this is uniplanar fixator. Over here, what you're noticing is, so suppose I show you an axial view. So this is the tibia, and you will notice that one pin is here and the other pin is here. So these are two planes, or perpendicular to each other, biplanar, or you can also call it orthogonal, biplanar or orthogonal, right? Here, what you notice, if I draw a section here, there is a pin that is been transfixing the bone, and there are rods here. So again, it is uniplanar but bilateral. Okay, and this is the ring fixator, the Ilizarov ring fixator. Now, please understand that the more hardware you attach to the bone, the more rigid or more stable it will become. Okay, that's a simple way for you to remember right now. But there are more things, right? It's a little more complicated than that, but I'm trying to simplify it for you. So if you can see this, this is a unilateral uniplanar external fixator with a single rod, right, with a single connecting rod. Okay. Here you notice that it's again a unilateral uniplanar external fixator with two rods. What do you notice over here? You notice that this is a uniplanar bilateral external fixator with two rods on both the sides. And this is unilateral biplanar or the orthogonal external fixator. And finally, here you notice that this the Ilizarov ring fixator, where there is a ring all around the bone and it is connected with pins, the olive wires or the olive pins in multiple planes, Okay, so the stability goes from here all the way up to here. So this one is the least stable. Uniplanar with a single rod is less stable compared to uniplanar with two rods, and Ilizarov or the ring fixator is the most stable external fixator. All right, are you following? So more the hardware, more the stable it will become. I mean, that's a simple way for you to remember. Okay, also remember the complications of external fixators. The pins that you put into the bone to hold the bone in place. Remember, what is the name of these pins? These are your Schanz pins. These are your Schanz pins. And the pin site, the site where you put the pin into the bone, has a risk of getting infected. Remember, so pin tract infection. Do you remember this pin tract infection? There was an MCQ that was asked. What kind of sequestrum do you get? You get a ring sequestrum at the insertion sites of the Schanz pin on an external fixator. This was a previous AIMS question. So this is a sequestrum. The dead bone is a dense bone. The dead bone is a white bone on X-ray. And these are the sites where you have inserted the Schanz pin into the bone. It has died. There are multiple reasons why there is sequestrum here. One of the reasons is when you apply the pin, the site where you're inserting the pin can get necrosis because of the heat of application, or because of frequent infections at the pin tract site. That is another reason why it can get infected and there will be a sequestrum. Also remember all the types of sequestrum that you should know for your exam. These are all the types, and the ring sequestrum we have talked about is at pin tract site. So let me go back to the question here. If you have to arrange it in terms of stability, this would be the answer. The most or the least stable would be uniplanar with single rod. More stable would be uniplanar with double rod, and then biplanar, and finally Ilizarov would be the most stable external fixator. Because if you recall, Ilizarov fixator is applied to patients, and then once it's applied, the patient can actually walk on the limb with an Ilizarov ring fixator because it's very, very stable. Okay, now friends, look at this question. A 45-year-old patient with a tibial fracture on cast presents to emergency department with complaints of intense pain. Okay, so there was a tibial fracture, cast was applied, and now he has intense pain. Now the cast was removed, and on examination, passive flexion was painful. Dorsalis pedis and posterior tibial pulses are present, and there is loss of sensation over the first web space. What is the next step in management? Measure anterior compartment pressure, duplex imaging, reapply cast, or give analgesics. Now, are you able to make the diagnosis just with the history that is provided here? There is a tibial fracture and patient complaining of intense pain. There was a cast that was applied for that fracture and the patient is complaining of intense pain. The cast was removed and there is pain on passive flexion. The dorsalis pedis and the posterior tibial pulses are palpable. There is loss of sensation in the first web space. First web space of the foot, it is supplied by your deep peroneal nerve, right? You remember that? Deep peroneal nerve. What is the next step in management? This is obvious case of compartment syndrome. You should be able to diagnose this. Now, some of you might be concerned that, sir, pulses are present. Pulses are present. If you recall, in the clinical diagnosis of compartment syndrome, pulse is the least important parameter and is the last to disappear. In fact, I've told you that if you wait for the pulse to disappear to make the diagnosis of compartment syndrome, unfortunately, you're already too late. Right? So pulse is least important. Here, what is happening is patient has pain on passive flexion. Extremely important clinical sign. Pain on passive flexion, painful, right? First. Second thing is that there is neurological deficit here. The structures inside the compartment are going into ischemia. They are suffering. They're going to die. So you have to intervene as soon as possible. The question is asking what is the next step in management? Measure the compartment pressure or do duplex imaging, reapply the cast or give analgesics. Giving the analgesics will not help. It's just symptomatic management. It will control the pain, but it will not stop the compartment syndrome. Reapply the cast. Yeah, joke. Make sure you do it so that you expedite the process of compartment syndrome and take the limb for amputation. Don't do that. Don't reapply the cast. The patient is in compartment syndrome. You have to remove any kind of covering. Third, get a duplex imaging done, color Doppler or venous. Why would you want to do that? It is again going to show you if the flow is there or not, but we don't care. Pulse is not important, right? Pulse is not important. Measure the anterior compartment pressure. Absolutely, that is the investigation of stress. That's what you do to diagnose compartment syndrome. Measure the compartment pressure. What is the normal compartment pressure? Normal compartment pressure is less than 10 millimeters of mercury. And what is diagnosis of compartment syndrome? If the pressure is more than 30 millimeters of mercury. And if you recall, I've told you, if the patient has low blood pressure, the delta P, the differential pressure, should be less than 30 of mercury to make the diagnosis of compartment syndrome. And once the diagnosis is made, friends, what will you do? You'll go for fasciotomy. So the answer here is measure the anterior compartment pressure. So let me quickly review what are the clinical features of compartment syndrome: pain, swelling, pallor, paresthesia, paralysis, and pulselessness. Pulselessness is the latest sign, is the last sign, is the least important sign that you can use to make the diagnosis. Normal pressure is less than 10, more than 30 is a diagnostic of compartment syndrome. Treatment is fasciotomy. Okay, and this is how you measure the compartment pressure. And fasciotomy has to be done for all the compartments, where you have to cut open the superficial as well as the deep fascia for all the compartments. That is posterior or lateral or anterior. All the compartments have to be opened up, and it has to be opened up throughout. Please remember that. That is your fasciotomy. And also remember a few confusing points that can be asked on your exam. Remember, a compartment syndrome is associated with both high and low energy injuries. It can occur in high as well as low energy injuries. Compartment syndrome can also occur in open fractures, which a lot of you will not believe me, but it occurs in open fractures also, because even though in open fracture, the fascia is already injured, but it's not the complete fascia that is injured. Okay, so that is why when you do fasciotomy, I'm telling you, you have to open up all the fascias, and you have to open up all the superficial and deep fascias of all the compartments. So for example, if a patient had a fracture, and that was an open fracture, and because of that fracture, a part of the fascia was opened, doesn't mean that everything is open. So other parts that are closed or enclosed by the fascia can undergo compartment syndrome. So that's what you do. And also, if a patient is unconscious, your suspicion should be very high, and measure the compartment pressure with the help of a manometer. Very, very important topic for your exam. Now, another clinical question that was asked on your unanswered exam was, following a femur fracture, your consultant asks you to provide tibial skeletal traction. Which of the following will you request from the nurse to do the same? Okay, so there is a patient who has a femur shaft fracture, and your boss or your consultant asks you to apply a skeletal traction to the tibia, that is upper tibial pin traction, UTPT. If you've attended your internship, you must have heard of this. And what are the instruments or devices that you will ask your sister to provide you so that you can apply it? Thomas splint, K-wire, Steinman spin, Denham spin, Bowler stirrup, Bowler Brown splint, or frame. Okay, so the instrumentation that you will use is basically very simple. You will use a Steinman pin, you will use a Bowler stirrup, and you will use a Bowler Brown splint. So correct answer is B356. But let me show you what this is and why we do this. So remember, whenever you want to give traction, there are two ways of giving it. You can give skin traction or skeletal traction. With skin traction, you use less weight because it's passing through the skin, and with skeletal traction you can use more weight, which is passing through the bone. So how do you apply this? You usually apply it in distal of the femur, proximal tibia, distal tibia, calcaneum. There are so many other places that you apply it to give traction, but usually the most commonly is the proximal tibia or upper tibia, UTPT, upper tibial pin traction. Okay, so what is the pin that you use to put into the tibia for the traction? So this pin that we use is called Steinman pin. Okay, it's a Steinman pin. It's a smooth pin. One side is trocard, other side is flat. Let me show you the image here. This is the Steinman pin. One side is trocard, the other side is flat, and it's a smooth pin, Steinman pin. And you pass it from the lateral to the medial side. Remember, you pass it to the lateral to the medial side. You make a small nick on the lateral side of the tibia, and then you put the pin, the trocar of the pin, on the tibia, and then you pass it medially. Why do we do it? Why do we enter from the lateral side? Because there is a common peroneal nerve here. You can't go blind, right? So if you insert it from the medial side and it comes out on the lateral side, it might injure the common peroneal nerve. So that is the reason you make a nick on the lateral side, feel the bone, and put the trocar directly on the bone and pass it from the lateral to the medial side. So this is the diagram showing you passing it from the lateral to the medial side. Now, once you've passed the pin, you connect this pin with the help of this stirrup that is known as Bowler stirrup. Okay, so this Bowler stirrup will be connected to the pin. Now it has a central circle here or a ring here that will allow you to tie the string or the rope of the traction. That's what it does. Right? That's what it does. So this weight, this rope will pull the ring, and this ring will pull the stirrup, and the stirrup will pull the Steinman pin, pulling the bone, giving you the traction. That's what you do. Okay, so this is an X-ray of showing you the pin here in situ with stirrup traction used for a femur fracture. Okay, now once you have done that, you can put the patient's lower limb on a frame. This is your Bowler Brown splint, right? And it has pulleys. It has 3 pulleys, 1, 2, 3 pulleys, and you can use the rope to pass on these pulleys to give you force in the direction that you need. Usually use this diagonal force because it is for the femur. Okay, so when you apply it, you pull it over here, and there will be traction for the femur. So these are the things that you will use for skeletal traction. Obviously, you will not use K wire because Kirchner's wires are very thin wires, 2 millimeters, 4 millimeters. They are used for small bone fracture fixation of tubular bones like phalanges and metacarpals and metatarsals. And remember, K wires are trocar on both the ends, and they are very thin devices. Another thing I want you to remember, Thomas splint, I'm sure all of you know what it is. Denham pins is something that I want you to remember. Denham pins is also a pin that looks like Steinman pin, although the only difference here is that in the middle of the pin, there are threads. The reason for this is that this is used for cancellous bones. You see, in a patient who has normal bone density, the bone is thick, and when you pass a smooth pin, when the weight is applied and the pin is pulled, causing the traction, the bone will hold the pin. Now, in an osteoporotic bone, as the weight is applied to the pin, because the bone is made so soft, the pin may cut out through the bone. So you would want some hold of by the pin to the bone with the help of these threads. So you use Denham pin, remember? Denham's pin in osteoporotic bones, or in bones where you're inserting the pin in a cancellous bone, for example, in calcaneum. So if you're inserting a pin in calcaneum, a Denham pin is used, but mostly in osteoporotic patients. So remember, Denham pins is used in osteoporotic patients. Otherwise, for skeletal traction, your straightforward Steinman pin will do. Okay? I hope you understand all of this now. Now look at this question from orthopedic oncology. Match the following with the best mode of management. Pathology is osteosarcoma, simple bone cyst, giant cell tumor, and osteoid-osteoma. And the management is wide excision, curettage, radiofrequency ablation, interlesional steroid. This is match the following type of a question. So osteosarcoma, a malignant condition, how will you manage it? Wide excision, curettage, radiofrequency ablation, interlesional steroid. Obviously not 3 and 4. 1 and 2, the answer is 1. We'll go for wide excision, where you remove the tumor as well as the healthy bone around it. Approximately somewhere between 3 to 10 centimeter of healthy margin is usually removed in wide excision. That is for osteosarcoma. Simple bone cyst, if you recall, the treatment is conservative or injecting the lesion with sclerosants or intralesional steroids. So the answer here is intralesional steroids. And giant cell tumor, if you recall, I've told you giant cell tumor and everything about giant cell tumor, extremely important. The treatment of giant cell tumor and aneurysmal bone cyst is extending the curettage. Okay, you curate it and you make sure that the cells inside the cavity are dead by either putting in the phenol or liquid nitrogen, or burning the cells with thermal cautery. So the answer here is curettage, although the better answer is excision curettage. And osteoid-osteoma is managed by NSAIDs, because osteoid-osteoma, I've told you, produces prostaglandins, and this causes night pains, which are characteristically relieved with aspirin or salicylates. If not, then you can go for radio frequency ablation. Ablation basically means destruction by radio frequency. So radio frequencies are used to destroy. So radio frequency ablation is the treatment of osteoid-osteoma. So the correct answer is this. So if you review the orthopedic oncology part, which I have taught you either in the regular videos or the revision videos, you would know the treatments of all of this, and we have discussed. Now let's look at this question. If the outer sheath and nerve fiber is intact and the inner axons are damaged, what is it known as? Neuropraxia, axonotomesis, Axonpraxia, neurotomesis. Okay, so what is this question basically asking you? If you recall, the question is basically asking you your SEDENS classification, right? Neuropraxia, axonotmesis, and neurotomesis. What happens in neuropraxia, axonotmesis, and neurotomesis? So here, what is it saying is outer sheath, nerve fiber is intact. So sheath is intact, only axon is injured. So only axon is injured. The answer is axonotomesis. If everything injured, the answer would be neurotomesis. And if nothing is injured, and if nothing is injured and the patient still has conduction defect, the answer is neuropraxia, right? So here the correct answer is axonotomy. So quickly review what it is. So at the interest of our nerve, at the center of our nerve, there is an axon, and each axon is surrounded by a sheath known as endoneurium. And many such axons with their endoneuriums are again surrounded by another sheath known as perineurium, which makes a fascicle. And many such fascicles are again surrounded by another sheath known as epineurium, right? That's a nerve. In neuropraxia, what happens is, because of compression, there is no actual injury, but because of compression, there is a physiological conduction block. So temporary physiological reversible conduction block. The nerve conduction velocity through the segment would be slow, and this is spontaneously recoverable, right? So the treatment is just splint. It is spontaneously recovers, and it recovers 100%. The examples are your tourniquet palsy and Saturday night palsy and crutch palsy, right? And in axonotmesis, only axon is injured, plus minus a few sheaths, but sheath should remain intact. Not everything is injured, because if everything is injured, then it is neurotmesis. So in axonotmesis, axon is definitely injured, plus minus a few sheaths. Nerve continuity is usually intact, and a neuroma is formed. This is known as a neuroma in continuity. And whenever there is a neuroma, there is a positive tinel. And because the neuroma is continuous, it will progressively recover at the rate of 1 millimeter per day. So that positive and progressive tinel will be there. There is motor march. Recovery will be there, progressive, gradual from proximal to distal, but never 100%. Okay, examples are in fractures and dislocations. And finally, neurotomesis, everything is injured, right? And there will be a neuroma, but this will be an endoneuroma. There will be no recovery. You will have to repair or reconstruct the nerve with the help of a graft in order for the function to resume. Obviously, the function will never be as good as the natural. Examples are lacerations or cut. So endoneuroma and neuroma in continuity, please understand what are the locations. Neuroma in continuity is seen in axonotmesis, and endoneuroma is seen in neurotomesis. You know this stuff. We have discussed this in great detail, and I'm sure you would be able to answer this. All right. Now let's look at this simple question. Which nerve injury causes this? It was one of these images. Now, obviously, you know what this is. This is your partial clawing of hand, because there is hyperextension at the MCP and flexion at the PIP and DIP of finger number 4 and 5. The answer here is ulnar nerve. I don't know why you would get confused here. Please remember, pointing index or benediction sign is this. Pointing index or benediction sign is then where the index finger and the middle finger are unable to flex. Middle finger may flex just a little, but the index finger will not flex. And the little and the ring finger will flex because there is a median nerve palsy. And in ulnar nerve palsy, there is partial claw hand. And in claw hand, you need extension at the MCP and flexion at the PIP and DIP. So ulnar nerve, partial claw hand, ulnar plus median nerve, complete claw hand, and median nerve, a pointing index or benediction sign. Straightforward, you know this. So quick review. Ulnar nerve is also known as musician's nerve. This is the sensory distribution of the ulnar nerve. And what is the autonomous zone of the ulnar nerve? Tip of the little finger. The lumbricals are supplied by ulnar nerve, especially the lumbrical 3 and 4, which supply finger number 4 and 5. And if they are paralyzed, this action is paralyzed. So there is extension of the MCP and flexion of the PIP and DIP. That is what your claw hand is. So this is your partial claw hand, and the splint that you use in claw hand, please remember, is knuckle bender splint, because there is claw, the knuckle that is MCP is extended. You would want to flex the knuckle, so bend the knuckle. Knuckle is extended, bend the knuckle bender splint. The test that you perform to diagnose ulnar nerve injury is your CART test, which helps you test for the interossei, that is palmar interossei, and Igawa test, which helps you test the dorsal interossei for abduction of the fingers. Book test is used to test for the adductor pollicis, which is a thenar muscle supplied by ulnar nerve. And what happens is, when you ask the patient to hold the book between the thumb and the index finger, and the examiner pulls the book out, the patient feels, because his adductor is weak, the book starts to slip. So he flexes the thumb to compensate for that loss. And when he flexes his thumb, the deformity is revealed, which means that his adduction is weak. And this is what is known as your Froment sign. So this is Froment sign. This is CART test. This is Igawa test. Everything we have read about ulnar nerve you know. And ulnar paradox also you should know. In high ulnar nerve palsy, that is ulnar nerve palsy that occurs at the elbow, because of the involvement of flexor digitorum profundus, the clawing will be less. And in low ulnar nerve palsy, because of the sparing of the FDP, the clawing will be more. So in high ulnar nerve palsy, low deformity, and in low ulnar nerve palsy, more deformity, and that is ulnar paradox. Another easy question that was asked: a 60-year-old woman with history of Colles fracture 8 months ago attained menopause at the age of 52, comes with a T-score of -2.5 on DEXA scan. She is currently asymptomatic. What is the treatment that you will give her? Hormone replacement therapy, estrogen, calcium and vitamin D supplementation, start alendronate stat, repeat DEXA scan in another 3 months. This is a clear-cut case of severe osteoporosis. There is osteoporosis and there is a history of fracture. So there is severe osteoporosis. And the treatment of osteoporosis, the drug of choice is bisphosphonates. Any kind of osteoporosis, the treatment of choice is bisphosphonates. So you should start the patient on alendronate. You can supplement vitamin D and calcium, but the treatment of choice is alendronate. There is no need to repeat DEXA scan in another 3 months because we already have a diagnosis of osteoporosis. Yeah, you can start the treatment and then you can repeat the DEXA scan a year later, but don't have to do it within 3 months because that's not going to change anything. What you need to do right now is start the patient on bisphosphonates. Also remember, if the patient has no fracture but you are suspecting osteoporosis, you should start the screening. The screening should be started at 65-year-old for females and 70-year-old for males. And this was also an MCQ that was asked. A quick review of osteoporosis. I've taught you osteoporosis in great detail in the regular videos, in the revision videos, and in the Delta session. Everywhere I have discussed osteoporosis, and I'm sure by now you must know everything about it. So quick review: labs are usually normal because it's a quantitative defect and not a qualitative defect. Earliest symptom would be pain, particularly in the lower back, because whenever the bone becomes weak before fracturing, it causes pain. Most common complications are vertebral compression fractures, followed by a hip fracture, then followed by a Colles fracture. The investigation of choice is a bone mineral density scan with the help of DEXA. It gives you a T-score, which basically measures the bone density of the patient with another young, healthy adult of 30 years, and you get a standard deviation score, that is T-score. 0 to -1 is considered normal, -1 to -2.5 is osteopenia, less than -2.5 is osteoporosis. If associated with fracture is severe osteoporosis, like a case in our discussion. The treatment is bisphosphonate, that is the drug of choice. All of these drugs basically inhibit osteoclastic activity. But if the patient has severe osteoporosis right now with fractures, you would want to increase the bone density. So you can use synthetic teriparatide. This is your anabolic that can increase the bone formation in low doses. This can be started. Abaloparatide or romosozumab can be used. Strontium ranelate, on the other hand, has both bone resorption inhibition action as well as a bone formation activity. It does both things. It can inhibit the bone resorption and increase the bone formation. Remember, all of these drugs over here inhibit bone resorption, and all of these drugs over here increase bone formation. The drug of choice is bisphosphonate, bisphosphonate, and bisphosphonate. And also remember, if you give bisphosphonate for a very long time, somewhere around 5 to 7 years, it can lead to atypical fractures. And these are your subtrochanteric fractures that occur at the lateral cortex. And just because of this fracture or this complication, you should not be afraid of using bisphosphonates. In fact, if you use bisphosphonates for a very long duration, up to 5 to 7 years only, you will see this complication, otherwise not. And that's why you can use bisphosphonates for 5 to 7 years. And even if there is a complication, in less than a few percent of the population, so don't worry about it. And so what we usually do is we use bisphosphonates for a good 4 or 5 years, and then we stop it for a few years. That is known as a drug holiday, so that this complication doesn't occur. And in those 2 years, we use alternatives that are available here. You have denosumab, you have SERM, so you have a teriparatide, you have romosozumab. All of these can be used. These are all second line drugs. And once again, after 2 years, we start the patient on bisphosphonate. So treatment of choice is bisphosphonate, bisphosphonate, bisphosphonate. We've talked about this in great detail. Now, there was a question here which had an image, and the image was basically labeled. The question was something like: following a fracture shaft of femur, cast application is done for a patient. Now, upon removal of the cast, the patient was unable to walk properly. Okay, so far here, the question was same. Now, there is a controversy here. Some students were saying the description of the gait after this was a little different. So we'll discuss both the variants. He was saying that he was not able to lift his leg and was dragging his foot. Okay, so this was one version of the question. People were saying that there was a history of fracture of shaft of femur, cast was applied, and then cast was removed. And after removal of the cast, the patient was not able to walk properly. And on examination, it was noticed that the patient was unable to lift his leg and was dragging his foot. The foot was dragging on the ground as he was walking. So this is one version. Other version was telling that as he was walking, he had to tilt his hip to one side to walk. So as he was walking, he had to tilt his hip to one side to walk. Which of the following structure is likely to have been damaged or injured? So there was an image, maybe a representative image, as in this graphical drawing of the hip, or in the anatomical dissection image of the hip. And the parts that were labeled were this: superior gluteal nerve, inferior gluteal nerve, and sciatic nerve. They were labeled. So superior gluteal nerve, inferior gluteal nerve, and sciatic nerve, these were labeled. So which of these structures have been damaged that can likely cause this problem in the patient? That was the question. So I really don't know what the exact question was, but let's discuss. So the patient was dragging his foot down as he was walking. What could it have been? It could have been your foot drop, right? Foot drop. And foot drop occurs because of common peroneal nerve injury. We know that it occurs because of common peroneal nerve injury. And common peroneal is a component of sciatic nerve. So sciatic nerve, if you take a section of the sciatic nerve, on the periphery is common peroneal nerve, and the central part is the tibial. Central part is the tibial. So if sciatic nerve is injured, the peripheral component, that is common peroneal, is not injured. So in other words, if sciatic nerve is injured, it is as good as common peroneal nerve getting injured, right? So if a patient has sciatic nerve injury, the patient will have foot drop. Okay, so that may be the answer. That could be the label that you can choose to mark as an option. Or if the other version of the question is the patient was tilting his hip to one side as he was walking, the question is maybe talking about Trendelenburg gait. The question is maybe talking about the Trendelenburg gait. And in Trendelenburg gait, remember, what are the structures that can get injured that will present to you as Trendelenburg gait? It can be gluteus medius and minimus, which is supplied by superior gluteal nerve. So the patient could have a superior gluteal nerve palsy manifesting as loss in function of gluteus medius and minimus, hence Trendelenburg gait. So based on what the question was, you could have answered it properly because you knew all of this. We have learned all of these things. So if a patient was talking, or the question was talking about foot drop, dragging the foot, unable to lift the toes, then common peroneal nerve is affected, means the injury is at the sciatic nerve. Or if the patient was tilting the pelvis as he was walking, then the question is talking about Trendelenburg gait. So you should have marked superior gluteal nerve, right? So I'm not in the exam. I was not in the exam. I don't know the exact question. Students are conflicted here. So discuss both of this. Next time, if it shows up, you'll be ready to answer however it is. So Trendelenburg test, quick review. What is it? It is basically a test to assess the abduction of the hip. Abduction of the hip. And the principal abductors of the hip are the medius and minimus. Medius is a better answer, and they are supplied by superior gluteal nerve. So any of this is affected will lead to Trendelenburg gait. Okay, so on nerve damage or muscle damage, the patient is unable to tilt the pelvis. See, when the patient is walking, we know this. I've discussed this. I've also discussed this in the delta session. When the patient is walking, one limb will be in the stance phase, the other limb will be in the swing phase. The swinging limb has to be brought up so that it doesn't sink. So the opposite side, the abductors basically tilt the pelvis to bring the swinging side up. If there is any pathology here, what happens? The healthy side will sink down. So I told you, sound side sinks. So if the right side is sinking, means the left side is pathological, right? So if left side is affected, the right side of the hip will tilt down. That is what it is. So when the patient stands on the left side, his Trendelenburg positive because his right side is sinking down. We have discussed this. We have discussed this in great detail. I'm sure you would have been able to answer this question. Just understand what the question was asking. If it was asking about foot drop, think of sciatic nerve. If it was talking about Trendelenburg gait, think of superior gluteal nerve palsy. Okay. And the last question, and this was a bouncer. I'm sure it was a little difficult for all of you, but if you would have gone to your postings in orthopedics and paid attention in the wards, you must have known how to do this. But nevertheless, I'll explain what this is. Arrange the sequence of performing a Thomas test. So basically, Thomas test, very relevant topic for exam, but now the examiner is asking you the steps of performing: squaring the pelvis, flexion of hip, overcorrection of normal side, check lumbar lordosis, measure the actual flexion deformity, ensure the ischial tuberosity touches the couch. Again, this is a recall question, so some options might be here and there, but that's not the aim. The aim here is to learn the steps of Thomas test. So basically, tell me what is the function and why do we do Thomas test? Thomas test is basically for flexion contracture of hip. We all know this. It's for flexion contracture or flexion deformity of hip. See, normally when you lie down, suppose this is your lower limb and suppose this is your pelvis and this is your lumbar spine. Say this is your head. Okay, all of them are in neutral position. All of them are in neutral position. And if you flex, say your lower limb, and this is your pelvis, and this is your lumbar spine. And if you flex your hip, this is how it would look like, right? So lower limb, pelvis, lower limb, pelvis, lumbar spine, right? All of them are neutral. And when you flex your hip, all of them remain in neutral. And when you again extend it, all of them are in neutral, right? This is how it normally should be. Now, suppose you have a disease of the hip where your hip is in flexion contracture or flexion deformity. Whenever the limb is in one deformity, the opposite action is unable to be performed, right? So if there is flexion deformity of the hip, it will not go into extension. But please understand that your spine, your pelvis, and your hip, all of them are basically compensating each other for function. So if there is a pathology at the hip which leads to its abnormal flexion, so patient will be unable to walk. So pelvis and lumbar spine will compensate this problem in the hip by exaggerating the lumbar lordosis and tilting of the pelvis. Okay, so this is what will happen in pathological hip where there is a flexion contracture of the hip. The lumbar spine will go into exaggeration, the pelvis will go into tilting, and your hip will be brought back to normal or will be brought back to neutral. Okay, so hip will be brought back to neutral by tilting the pelvis and exaggerating the lumbar lordosis of the lumbar spine. This is what happens in pathology. Okay, what is the pathology? Flexion contracture of the hip. Because there is flexion contracture of the hip, the pelvis and the lumbar spine are compensating and neutralizing the flexion contraction so that the patient should have straight limbs. Okay, that's how he can walk and stand and lie down. Now, when this patient lies down, what will you notice? That his lumbar spine will be exaggerated. In normal patient, it was flat, but in patient who has flexion contracture of the hip, the lumbar spine is exaggerated. That is what you're looking for in Thomas test. In Thomas test, when you make the patient lie down, who has a flexion contracture of the hip, the lumbar lordosis is exaggerated. So you make the patient lie down and you observe his lumbar lordosis. If it is exaggerated, it means there is some problem there at the hip which is being compensated by pelvis and the lumbar spine. So what you do here is, remember the name of the Thomas test is Thomas well leg test. So what you do is you take the normal side. And flex it. You flex it. When you flex the normal side, when you flex the hip of the normal side, what happens? The compensated pelvis tilts back to neutral, which will bring the compensated lumbar spine to flatten once again. And when this happens, the pathological side will start to reveal its flexion deformity. Are you following me? So when you flex the normal side, the pathological side will start to reveal its deformity because the compensators are neutralized. Are you following me? So if left side is pathological, you flex the well leg, that is the right side. When you flex the right side, it neutralizes the pelvis and the spine. And when the pelvis and the spine are neutralized, the pathology reveals itself. And that is the flexion deformity. And that's how you measure the flexion deformity of the hip. So in summary, Thomas test is a test that will reveal the concealed flexion deformity of the hip, right? And who is concealing the deformity? The pelvic tilt and exaggeration of the lumbar lordosis, right? So that is what you do in Thomas test. So let's go back to the question here and look at the options. Squaring of the pelvis, no, we don't do this. Flexion of the hip, yes, we do this. Overcorrection of the normal side, we do this. Check the lumbar lordosis, we do this. Measure the actual flexion deformity, yes, after flexing the normal side, and ensure the ischial tuberosity touches the couch. Also, we do this. Why do we do this? Because when you're flexing the normal side, friends, if you do it beyond a limit, the pelvis will lift up. So not only will it go into neutral, it will go beyond that. So you have to make sure that the ischial tuberosity is still touching the couch and the lumbar lordosis is obliterated. Okay, so those are the steps you do, and based on that, you whatever options were there in the exam, you could have marked this. Now you know how Thomas test is performed. Okay, so Thomas test is a test that is going to reveal the concealed flexion deformity of the hip. And why is there deformity? There is a flexion deformity of the hip. And who is concealing it? Tilt in the pelvis and the lumbar lordosis is compensating for the flexion contracture of the hip. Did it make sense? Right? And which side do you flex? You flex the well-leg side or the healthy side. And on flexion, you bring the pelvis and the lumbar spine back to neutral, thereby obliterating the lumbar lordosis. And by obliterating the lumbar lordosis, you are neutralizing the compensation, and the contracture of the pathological side will reveal itself, and then you can measure it. And that's what happens. Look at this patient. If a normal healthy patient flexes his normal healthy side, nothing will happen. But if a patient who has flexion contracture, if he flexes the normal side, the pathological side will start revealing its deformity. Did you understand? Did you understand? I know it's a little complicated, but you should know this now because it's a very relevant test for your exam. Go and do it once in your ward and ask your resident. I'm sure they will help you understand this. With that, we have completed all the recall questions that were asked in your November INI set. It was not a very hard exam. A lot of you were telling, a lot of orthopedic questions were hard. I don't think they were hard. There were only two questions that were probably hard for you. One is the external fixators and the types of external fixators based on their stability, and the others were the details of Thomas test. Otherwise, everything that is osteoporosis, nerve injuries, anatomy, and compartment syndrome and open fractures, they were all standard questions that were frequently asked. Right. With this, I hope you understand that reading things is important, but also knowing everything around it, especially in the clinical aspect, is relevant for INI set exam. I wish you guys all the best. I will see you on the other side. Bye bye.